Hello, everybody, and welcome to this week's EASL Studio, your weekly hepatology broadcast. Today, we are zooming in on the clinical blind spot in hepatology. Are we neglecting alcohol? And before we start our introductions, I want you all to imagine doing rounds. And you're entering the room of Paul. He's a patient in his 50s. Paul is the archetype of a patient with alcohol-related liver disease. It's his fifth time in the hospital this year alone. He is sarcopenic. He requires large volume paracentesis. He's hospitalized with a severe urinary tract infection and hepatic encephalopathy. So in terms of chances for long-term survival, I bet you do not give Paul very good odds. And my three guests today are all familiar with the huge role that alcohol plays for liver-related morbidity and mortality in so many patients with end-stage chronic liver disease around the world. And with that, I warmly welcome you all three. Mzamo Mbelle, gastrohepatologist and clinical research fellow at King's College London, previously Johannesburg Academic Hospital, welcome. And Brian Lee, transplant hepatologist and associate professor of medicine at University of Southern California. And Elisa, specialist hepatologist and associate professor at Hospital Clinic and University of Barcelona. So Paul is in the hospital ward, but in contrast to the reality that we meet in hospital patients, where patients like Paul take up most of the beds, ALD is surprisingly almost invisible in population-based studies, and this is what we are going to touch upon today. So the most recent data are from a meta-analysis this year where the pooled prevalence of alcohol-related liver disease among all steatotic liver disease patients was down to only 6%. So in my opinion, there's a clear discrepancy between the estimated population prevalence of alcohol-related liver disease and the mortality and morbidity that we all know and experience firsthand as clinicians. So with this kind of conundrum listed up, I want to hear the three of you. So we can maybe later come back to why this discrepancy between the population-based estimates and the reality in clinical practice exists. But before we do so, if you can imagine seeing Paul for the very first time and you're somehow suspecting alcohol may play a role for his newly diagnosed cirrhosis, what would you personally do to demask the burden of alcohol in Paul? Maybe we can start with you, Mzamo.
Thank you so much, Maja. Yeah, you've highlighted quite I would say a conundrum, the clinical conundrum that we often face, particularly in the outpatient settings. Of course, there are different kind of populations, and we will obviously touch on that a little bit later on in this discussion. But I think it's always good to start off with kind of open-ended questions, and likely I would often kind of, in a very calm manner, start with, well, how often do you drink alcohol? And I find this is always a good way just to start, and then take things from there.
So this is your first question to Paul, or do you kind of gradually ease your way into it?
Yeah, certainly. I think you have to also consider kind of the context and kind of some, let's say, cultural norms and things like that with certain patients. But I mean, when we are kind of getting to the nitty-gritty, I think while starting things quite open-ended, I like to really kind of define, because often, they're different. Yeah, I think getting direct is often a good way to start from my side, and then kind of gauge where the patient's at from there.
Mm-hmm. Mm-hmm. So when you're taught about a brief intervention, there's always like a recommendation to ask for permission, kind of, to the patient. They're saying, okay, can we discuss alcohol? I want to kind of take Mzamo's direct approach and maybe push it over to you, Elisa. Are you also a fan of the direct approach, or do you sort of ask for permission first? How do you approach it?
Well, I think it's a difficult question. We in the clinics we try to start establishing a link with the patient before. Maybe we discuss about his or her life conditions, her work, family, whatever. And the alcohol questions like arrive at the end of when we have already discussed a little bit. We also use this strategy of doing like open questions to the patients and like also trying to avoid like labeling or accounting for alcohol like in the beginning, because when the patient starts like to open and probably the amount of alcohol that he or she declares are back or not like very precise, and we kind of let him or her like discuss about it like with support and like showing acceptance and not labeling, you know, like not saying in the beginning, okay, so you drink X units of alcohol per week or per day, no? So that
And
way.
as a practitioner in Barcelona in Spain, what is your experience? How many of your patients, when they come for their very first visit in the liver clinic, how many have no problem discussing alcohol, and how many do you need to kind of drag it out a little bit?
Yeah, it's we maybe I can say we received and visit two types of first visits. One of them are patients referred from other hospitals. In these cases, patients already have a diagnosis of liver disease, and they, in most of the cases, they know it is caused by alcohol. So this topic has been discussed before. So even in those patients, in some of them, we find difficulties like to try to find like the good way like to get information from their alcohol use, and also for them to be confident and to feel in a safe environment to declare it. And then the patients that we receive that don't have a diagnosis for a alcohol-related liver disease, in these cases, you know, in many cases, patients don't think that alcohol has harmed them that much. So you have to start from the beginning and at some point, like discuss on the harms of alcohol when during the visit, you know.
And maybe to you, Brian, so what's your approach? Do you also go for the open-ended questions, or do you perhaps use questionnaires prior to the interview?
I think you have to personalize it to the patient in the end, So my approach is typically that, in the end, acutely and in the short term, all decompensated liver disease really looks the same, right? Long term, it's when you're trying to really address the alcohol-related specific problems. So, I really start about talking about their liver disease, when were you first diagnosed with liver problems, what's your understanding of how severe your liver problems are, and then I ask them, what do you think caused your liver problems? And sometimes they're very forthcoming, right? Most patients are, in fact, they tell you that they drank too much, they've been having too much alcohol, and that makes it very easy, right? But it's a really natural segue to also ask if they say, well, I don't know, or, no one's ever really told me. And then you know that you have to actually approach this in a more kind of sensitive fashion. And that's really where I use the open-ended approaches. I talk about how there are different causes of liver disease. And then within that, jumbled with, maybe kind of metabolic risk factors or, ingestions, et cetera, I talk about alcohol. And to me, it's a natural way to just, in a non-judgmental approach, ask about alcohol use.
But I don't hear any of you kind of prior to the consultation actually having replies on, for example, the audit questionnaire, the alcohol use disorder questionnaire provided by the WHO, or the audit C, which is a shorter three questionnaire, because that could be a good entry into talking about alcohol.
Yeah, perhaps I might have glossed over a little bit. We do certainly have some of those things within our service, particularly with your specialist clinics as well. So sometimes your undifferentiated clinic, or indeed your alcohol services or alcohol and substance use services. Often some of these patients will already have completed either themselves on the EPR, or indeed, there'd be some the healthcare workers out in the clinic, on the clinic floor, and that's pre-populated. So once they're coming in, then now you can kind of really address the issue. I think often things maybe get a little bit muddled or a little bit confusing if they let me say there's some the kind of there's a excuse me, sorry. Sometimes they can get a little bit confusing if they contradict each other, for example. So for one of the scores might be slightly contradictory.
And Brian, I'm really curious because I know in the VA system, at least, I think they provide the audit C to anyone referred, regardless of the etiology. Are you doing something similar in California?
At USC, we haven't implemented that systematically, but that there are, the VA system, which is our veterans network, where they've implemented really asking the audit C in all primary care settings. And, the completion rate is really good. It's 90%, and it's thought that it's really uncovered alcohol use disorder that wouldn't have otherwise been apparent during the visit. There are other health systems, for example, Kaiser, which is a large health system in the US, which has used the NIAAA single questionnaire, which is even shorter than the audit C. But this idea of, yes, it can be implemented, but in our own practice, we haven't done that, in fact.
Elisa, I know you are seeing a lot of patients referred from alcohol detoxification units. So I guess in those cases, it's really people who already have a self-acknowledged high alcohol use. How do you then track alcohol use in those patients where remaining abstinence is really important for their liver health?
Well, yeah, we started like some years ago doing screening for liver disease in all patients with AUD that from our addiction unit in our hospital. The experience is like really good for us and also for the patients. I think in this case, we have a lot of the work like done by our colleagues, psychologists and psychiatrists, because they are the ones, not the first specialist dealing with alcohol use problems in these patients. I should say that the feedback from the patients is like really good, because even if they are aware of the problem that they have with alcohol, the majority of them are like really grateful of being like of having their liver analyzed and tests, and most of them have never undergone like or a lab test with a liver profile, not of course a transenastography or even an ultrasound. So I think it's a very good opportunity like there, like to deal with alcohol problems and to set up like or to start a conversation on the harms of alcohol in the liver, and like patients like really welcome it in the majority of cases.
And what about alcohol biomarkers? Because I guess one thing is kind of untangling the use of alcohol in a patient you see for the first time, but for monitoring, and especially for those where it has a real importance prognostically to remain abstinent. I assume alcohol biomarkers can and will be used to a higher and higher extent in the coming years.
Yeah, for sure. In our case, our colleagues from the addiction unit, they do urinary ETG twice per week in the majority of the patients, and they are really support this strategy because they say that it is like a part of the therapy, for the patients also to get a direct feedback and a direct control of alcohol use, because they receive a very direct information. If they have drunk in the previous days, they do know the result is positive. They have in very small period of time, they have a result of what they have been doing, and then when they go to the visit, they are like really open, because the results are there. And I think it's a good strategy. It works well for us.
And so urinary ETG has quite a short half-life, so you get the past 2 or 3 days of alcohol use. But I think, Brian, in California and LA, you use PEth, right, as a biomarker?
Yeah, so we used to use urine ETG, and now with the availability of blood, phosphatidylethanol, PEth, we've really kind of completely moved to that. ETG, I think, was nice, but it has the problem with some false positives. With any kidney dysfunction, it can also overestimate the values or even result in false positives. So blood phosphatidylethanol, although more expensive, it gives you a longer time window, so 28 days of drinking. And it also technically has no false positives. So that's what we've really moved on to, and kind of what Elisa was, we use it in the same fashion. We use it particularly with first diagnosis. If someone doesn't report alcohol use, we use PEth because we found that we've discovered covert alcohol use when a patient didn't admit to alcohol use, and we find that some values are very high, meaning there was definitely a component of alcohol. And then
so could you, maybe, sorry for interrupting, but how often does this happen? How often do you see a patient and you have no self-report of excessive high alcohol use, and then you get the PEth results and it's surprisingly high?
Yeah, so in research, even in MASH cohorts, for example, where a patient is supposed to have non-alcohol steatotic liver disease, people will report 10 to up to 20+%, even sometimes 30% of patients who have positive alcohol biomarkers who didn't report alcohol use. In my practice, it seems about the same amount. I would say 20 to 30%, which is significant, right? It can really alter your management of this patient. So we found it extremely valuable in the first diagnosis visit to use PEth.
Yeah, and what's your approach then? I mean, we've all talked about open-ended, unbiased questions, and then you have a patient, they self-report little or no alcohol use, but then you get a PEth result of 100 nanograms per milliliter, so significantly elevated. How's your approach to discussing alcohol after the PEth result?
I think there was a lot of concern before we implemented PEth that, oh gosh, patients will feel like they're being, drug tested and stigmatized against. But in the end, I think that is really not borne out to be the case. We really use it indiscriminately. It's just routine care. And when you explain that to a patient, they're very open to that in my experience. So, I would say that when we've done this, I really approach it that I ask them about their alcohol use. They'll say that they don't drink. And I show them that, we have actually, a blood test to look for alcohol use, and this has been positive. And then they'll say like, oh, maybe I had one drink, for example, is an often, approach. And I say, well, usually at this level, it's at a much higher level. And I find about half of patients after that, they'll be very forthcoming when they realize how, non-judgmental they are. I always tell patients, over half of my patients have, liver failure from alcohol. So nothing you say, will ever surprise me, and nothing you say I'll ever judge. Okay, I always preface that conversation with that, and I feel that about half of patients are kind of open. And then, kind of the other half, they're still not ready. And, I kind of leave it at that. I really let them go at their own pace. But, when they come for follow-up, I continue to test. And if they have improvement in their biomarkers, I've showed them, for example, the linkage to PEth. And I found, PEth is still pretty new for us, but I found there's a pretty significant amount of patients after a couple of visits, and you show them that linkage, that they really open up and start talking about their alcohol use, and they tell you about their problems cutting down on alcohol. And I found that PEth, from that standpoint, to really open the conversation, has been really so useful.
Mm-hmm. So with with everything we have today, we have interview techniques. We have, as a hepatology community, improved vastly in our interview techniques and being unbiased, using open-ended questions, etc. We have the well-validated alcohol use disorder questionnaires. We even have highly accurate direct alcohol biomarkers. And still we have these, let's say, population-based studies with very low percentages of alcohol-related liver disease. And a lot of these studies have come in the last couple of years after the steatotic liver disease nomenclature, where alcohol-related liver disease was sort of put under the umbrella of a spectrum of steatotic liver disease, moving from MASLD into MetALD and then ALD. So obviously this sparked a lot of research, but when we look at the data and we look at the very small role that alcohol plays in those data, could we actually say that the SLD nomenclature has done alcohol-related liver disease a disfavor by sort of minimizing the problem, at least in the population-based studies? What do you think? Who wants to go
Wow.
first?
Well, you know,
Mzamo,
I think
I can start with you.
Yeah,
You're
yeah.
smiling.
Well,
We say it can be
I'm
used
not too sure.
against us.
I must admit, I come from, let me say, I've got two different hats on, and in this conversation, right, from the kind of history, how we, the cultural differences, maybe how we might approach patients, or through what we have, the biomarkers, for instance, are we using your kind of your blood-based biomarkers, or maybe some subtle tests, your liver chemistries, your MCV, those kind of things on the one hand, and then on the other hand, we have the ETGs or PET testing. But when it comes to, let me say, let's say the burden, at least if I can say from an African perspective, it's quite clear that there's a significant discrepancy, I would say, between what we get, and more so than perhaps what I'm seeing this side. In that what we're getting, you mentioned the meta-analyses and population data saying about 6 or 7% alcohol use disorder at similar in Africa, but that's based on 2 studies, and that ranges where all in sub-Saharan Africa. And I think the big issue, at least, or one of the issues I find, particularly on the African continent, is that lack of research, and lack of population data, lack of lack of research, I think, is a big thing, and it might be an awareness issue, either from us as healthcare workers or the research community, or it might be related to some of those kind of stigma, socioeconomic issues with our patients. So I don't know whether or not the nomenclature itself now it seems to, let's say, destigmatize or make that a little bit easier. Perhaps it might, but I'm not too sure at this stage. I'm not sure about my colleagues, what they think. Yeah.
But maybe we can stick a little bit with your unique situation, but because you're now practicing in the UK, which almost take pride in their alcohol use, as does many other European countries, right? But you have also practiced in Johannesburg in South Africa. Is there a difference in stigma towards alcohol and alcohol-related harms in the two
Yeah.
places?
I think they're vast differences. I think, firstly, we were talking about how you ask about alcohol use. I think one of the big things that perhaps comes up in that context compared to here would be what kind of alcohol use. We have this, if I can say, home brews or kind of informal alcohol, and I know perhaps even in the West it kind of got a little bit bigger, as a result of the pandemic. But that's certainly something that's pretty common back home. And let's say you come from a certain region, you don't speak a certain language, you might not be able to get that history. That someone's even taking alcohol, or because you wouldn't even ask for the right thing, for instance. So I think that's the one side, is actually knowing to ask for kind of other kinds of alcohol use. But I think the stigma is dependent on different things. There's certain, multicultural, especially South Africa is multicultural. You do have those individuals who are, as you say, quite proud to mention how much alcohol use how much alcohol they're taking. But on the other hand, you do have people who are a little bit more modest, or there might be that stigma of liver disease. And, obviously, or previously it was a viral hepatitis that was kind of driving morbidity from cirrhosis and HCC and those complications. But similar to the West, your disorders of lifestyle, so MASLD and alcohol, are increasing quite significantly. So with that, I think the stigma is also increasing.
Maybe we can save a little bit what to do about the stigma, which I think is an obvious and clear problem still across the globe. Definitely getting better, but work to be done. And go back to the point you had, Mzamo, about the SLD nomenclature kind of being destigmatizing, because you suddenly have a disease that is under the umbrella of steatotic liver disease. And maybe if I can turn to you, Brian, and yes, ALD is under the umbrella of steatotic liver disease, but it begins with steatotic, so focus may be on the kind of more metabolic unhealthiness and on the liver steatosis rather than on the real driver of disease, which is alcohol. What do you think?
I think it's kind of a double-edged sword, right? I agree with you that, moving under the umbrella, it's caused some issues in terms of how it's defined, how it's studied, et cetera. But I see a lot of benefit, right? I haven't seen this much interest, especially from an industry standpoint, in investing in potential interventions in ALD in many years. And I think that's a direct kind of result of this new nomenclature, right? This idea that, well, ALD is just a steatotic liver disease, right? And that many of these investment that's been made in MASLD, to really intervene on steatohepatitis may be influential in ALD because it is a steatotic liver disease. So to me, that's been the prime benefit. And, I'm very excited to see what will happen.
Mm. Maybe no one of you dares take a jab at the steatotic liver disease, and that's also okay. But there are, as you say, Brian, and I fully agree. There's a lot of research going on, and it's so interesting also to have pharmaceutical players coming into this field who previously shied away from developing drugs. But Elisa, like there's a phase 2 study using GLP-1 analogs for alcohol-related liver disease or MetALD. And I mean, should we really tell patients with ALD to lose weight when they need to stop drinking? To kind of put it roughly.
I think I agree with Brian that the new nomenclature poses like a great opportunity for people from the ALD field, people working with patients with ALD to progress and to make progress in the field. But I think that we should remain strong on which is the main driver of disease, which is the main driver of prognosis in our patients, in patients with ALD and even in patients with MetALD. The main driver of prognosis is alcohol. So we should not diminish the importance that it has. And going back to the case that you presented of Paul in the beginning of the session, you presented the case of a man who was like hospitalized and admitted to hospital many times before. I think that if in this patient no one has previously done an intervention and repeatedly tried to engage the patient on a therapy for alcohol use, it is a failure of the system, because we should be aware that patients do have two conditions. They have a liver disease, but they do have an alcohol use disorder, and both should be treated from the beginning. No, and this, I think that should be clear from a clinical perspective and also from a research perspective when analyzing new drugs in new trials, etc. I think that those trials should be aware that standard of care should include psychotherapy for alcohol use disorder.
Yeah, for sure. So we are now at we're closing in on the ending of this EASL Studio, but we have a scenario where the current in-hospital mortality statistics show a vast burden of alcohol-related liver disease and alcohol's role in mortality and morbidity, while on the other hand, the population level data make it almost invisible. So now you each get one jab at kind of what is your idea for showing the true burden or the true prevalence of alcohol as a factor in population-based studies. What would be your tip as the most important sort of mechanism for revealing alcohol's role? We'll start with you, Brian.
Well, it's important to really understand where the population estimates are coming from. So, most of the population estimates, when they're quoting single digits for ALD, they're survey-based studies. So what they're doing is they're taking, the population and they're using a survey to ask what their alcohol use was in the last 12 months. Okay, but that has a very high, positive predictive value. So if someone's reporting high alcohol use in the last 12 months and they have liver disease, okay, that has, you're pretty definitive that person has ALD. But what you're missing is one, people who drank a lot in the past and have kind of slowed down or stopped drinking. Okay, and then two is you have to understand the nomenclature is actually giving a very high bar for what we constitute as ALD. You need to drink 30 drinks per week as a man to be considered ALD. Okay, so that means if someone is drinking, 12 beers on a Friday, 12 beers on a Saturday, every single week, they're only MetALD. They're not ALD, right? They don't meet that threshold. So that's why these estimates are very low. It's because it's a very high positive predictive value. Okay, but you're really not capturing historical drinking and those who might not be drinking quite at the threshold that the nomenclature is asking for on an average every single day.
Okay, thank you. Mzamo, Mbelle, what's your one idea for revealing alcohol in a more accurate way?
Yeah, I mean, I would say coming back from let's say my one hat, but my back home hat, I think one big thing is awareness and maybe the role of kind of interventions on a public health level, whether it be, kind of engaging governments and those kind of things. Certainly there's not a lot of that happening within the space, at least when you compare to things like viral hepatitis, where quite clearly there was an issue, a pandemic, as you will, and that's been, well, it's only one of the interventions, of course, but that's really shown quite that intervention has shown to be very impactful in viral hepatitis.
Yeah.
There seems to be a lot of that going around MetALD now, and I think maybe it's just it's the flavor of the month, I think, when it comes to liver diseases. But hopefully, or I would say that in the alcohol space, that certainly isn't the case, and there aren't really champions of that. And I think that might be some low-hanging fruit, at least within that context.
So we have more sensitive questionnaires from Brian. We have more awareness, including in the population about alcohol. Elisa, you get the final jab.
Yeah, well, I think that from like if I can add something from our perspective as clinicians, what we can do, like to unmask or to help to unmask alcohol use in the general population and also in our patients, is to start asking a lot more about alcohol use in our patients as a standard practice in community, in primary care, in secondary and tertiary care, because it is a question that many times is not dealt with enough attention. So underreporting in many cases is also kind of favored because there are not enough skills or time or dedication from the professional that is dealing with this problem.
Okay, beautifully put. We end up putting the arrow at ourselves and our ability to demask alcohol. Thank you so much for excellent discussions, all three of you. And with that, I want to thank you all for tuning in to EASL Studio. Remember to tune in next Wednesday, where we take a closer look at acute and chronic liver failure and the questions that really matter for clinical practice. See you next Wednesday.